Welcome back to the deep dive. We are tackling a topic today that sits right at the intersection of terrifying and incredibly important to know. If you have aging parents, or if you plan on aging yourself at some point, which I assume is all of us, this is going to be relevant. We're looking at a brand new study published just this month, February 2026, in the Lancet, and it challenges a narrative that I think we have all just sort of accepted.
It really does. It overturns a very specific medical comfort blanket.
The comfort blanket. Okay, so it's this. You take an older relative to the hospital. Maybe it's your dad. He has a UTI, or maybe, I don't know, a minor hip surgery. He goes in, he's himself. But 2 days later, you visit, and he's gone. He's confused, doesn't know where he is. Maybe he thinks the nurse is his cousin. It's scary. But the doctor comes in and says, don't worry.
It's just delirium.
It's just delirium. It's the medication or the change in environment. It'll clear up when he gets home.
Right. It's a temporary fog. That is the standard line.
And, to be fair, usually the confusion does clear up. The fog lifts. Exactly. So we breathe this sigh of relief. We take Dad home, and we think, okay, bullet dodged. But this paper suggests that the bullet wasn't dodged at all. In fact, it suggests that the fog wasn't just a side effect. It was a massive, flashing red warning light that the entire system is in trouble.
The authors of this study call it a sentinel event.
A sentinel event. We're going to unpack that term because it sounds ominous. But first, let's look at the source itself. This isn't some small survey. This is the UK Biobank.
Which is, it's the gold standard for this kind of population health data.
Yeah.
The sheer scale lets researchers see patterns that smaller studies they just miss them.
So lay out the numbers for us. How big was this deep dive into delirium?
They looked at a massive cohort. Specifically, they identified 14,909 individuals who had an episode of delirium during a hospital stay. These were people recruited across England, Scotland, and Wales.
Nearly 15,000 people. That is a significant sample size. But here is where I always get skeptical with these kinds of studies, and I want you to walk me through this. We are talking about older people in the hospital. By definition, they're sick. If you are sick enough to get delirium, aren't you just sicker?
You're asking if this is just a correlation.
Right. Of course, the person who got confused is going to have worse health outcomes later than the person who didn't. They were probably frailer to begin with. Is this study just telling us that sick people stay sick?
And that is the most important critique to make. And honestly, a lot of previous research got stuck on exactly that point. But this study did something very, very clever to get around it. They used a process called propensity score matching.
In plain English.
They found medical twins. For every single one of those 15,000 patients with delirium, they hunted through the database to find a control patient, someone who didn't have delirium but matched them on almost everything else.
When you say everything else, what are we talking about? How deep does that go?
Same age, same sex, same primary diagnosis. So if the delirium patient had pneumonia, their twin had pneumonia, same length of stay in the hospital, same time spent in the ICU.
Okay, that's already pretty rigorous.
But they went one step further. They matched them on the hospital frailty risk score.
So they are comparing a frail, sick 75-year-old with pneumonia who did get delirium against a frail, sick 75-year-old with pneumonia who didn't.
Exactly. They leveled the playing field. So if we see a difference in what happens to them a year later, we can be much more confident that the delirium itself is the marker of that difference, not just the background sickness.
That context changes everything. It means we can't just write this off. So let's talk about the results. They tracked these twins for a long time, records linked all the way through October 2022. What happened to the people who had the delirium?
The short answer is nothing good. The study looked at 15 specific adverse clinical outcomes, basically bad things that can happen to your body. Delirium was associated with a significantly higher risk for 12 of them.
12 out of 15. That's a wide net.
It is. And the types of things on the list are what make this sentinel event theory so compelling. We often think of delirium as a brain problem, so you'd expect maybe dementia or stroke to be the main risks. And they are on the list. But the highest risks were surprisingly physical, functional.
Give us the top one. What was the number one risk predictor?
Urinary incontinence.
Really? Losing bladder control?
Yes. The hazard ratio was 2.01.
So double the risk.
Basically, yeah. Compared to their medical twin, the person who had delirium was twice as likely to develop urinary incontinence in the follow-up period.
I feel like we need to pause on that because it sounds, mundane. Like compared to death or heart attacks, incontinence sounds like an annoyance. But for an older adult, that is a life-altering diagnosis.
It's huge. In geriatrics, We call these the giants. Incontinence is often the tipping point that moves someone from independent living to a nursing home. It leads to social isolation because people are afraid to go out. It leads to skin infections. I mean, it creates a cascade of decline.
And it connects to the second highest risk on the list, doesn't it?
Falls.
Which makes sense if you're rushing to the bathroom.
Exactly. The risk of falls is 1.96 times higher, almost double. And again, think about the why. Delirium is a sign of brain failure. If your brain is struggling to process reality, it's probably also struggling with gait, with balance, with processing the environment. That vulnerability doesn't just vanish when the hallucinations stop.
And the third one.
Pressure injuries, bed sores, 1.72 times the risk.
So we have a triad here. Incontinence, falls, bed sores. This is a picture of rapid functional decline. This isn't just grandpa's a little more forgetful. This is grandpa can no longer take care of his basic bodily functions.
Correct. And that is why the authors use the term sentinel event.
Let's dig into that term. I usually hear sentinel in, like, a military context, a guard standing watch, or maybe in tech, like a monitoring system.
In medicine, a sentinel event is a warning signal. The classic analogy is the canary in the coal mine. The canary is small and sensitive. If there are toxic gases in the mine, the canary stops singing and dies long before the miners feel sick.
So delirium is the canary.
The brain is the canary. The brain is the most energy-hungry, sensitive organ in the body. If your body is under stress, from an infection, a surgery, dehydration, the brain is often the first thing to glitch. It's the check engine light.
But the mistake we make is thinking that once we fix the glitch, once we give the patient some haloperidol, or they wake up the next morning making sense, that the car is fixed.
Right. We put tape over the check engine light because it stopped blinking. But this study says the engine is still compromised. And it's not just the brain engine, it's the whole car. Because the study didn't just find functional issues like falls, it found organ failure.
This was the part that really surprised me. I get why a confused person falls. I get why they might have incontinence. But the study linked delirium to kidney failure.
Acute kidney injury, or AKI. The risk was 1.71 times higher. And sepsis, a life-threatening reaction to an infection, was 1.67 times higher.
Walk me through the mechanism there. How does a brain episode in February predict that your kidneys are going to fail in December?
That is the multisystem vulnerability theory. The idea is that the delirium is a marker that the body's reserve is just depleted. Maybe there is chronic, low-level inflammation simmering in the background that hit the brain first, but is slowly chewing away at the kidney tissue too.
So the fire was already burning in the walls. The smoke just came out of the chimney, the brain first.
Exactly. Or it could be vascular. If your blood vessels are stiff or damaged enough to cause low blood flow to the brain during stress, causing delirium, well, they are probably also doing a poor job of perfusing the kidneys. The delirium unmasks the hidden damage throughout the system.
It really challenges the way we silo medicine, doesn't it? You have a neurologist for the brain, a nephrologist for the kidneys, an orthopedist for the hips. But this study is just screaming that the body is one single connected unit.
And if that unit fails a stress test in the hospital, which is what delirium is, a failed stress test, you have to assume the whole unit is fragile.
I want to ask about the timeline here. You mentioned they tracked people for up to 26 years. Are these bad things happening 2 decades later? Because if so, that just feels like, well, aging.
That's a key distinction. While the data went back 26 years, the median time to these adverse events was about 1.2 years.
1.2 years.
So we are talking about the immediate aftermath. The danger zone is the 12 to 18 months after discharge. This is an acute window of vulnerability.
That makes it actionable, though. If you told me this predicts a fall of 20 years, I can't do much with that. But if you tell me your dad is in the danger zone for the next year, that changes how I parent my parent.
It should completely change the discharge plan.
Before we get to the what do we do part, there was another finding about exposure intensity. Basically, does it matter if you have delirium more than once?
It absolutely does. They found a dose-response relationship.
Meaning the more doses of delirium you get, the worse the outcome.
Exactly. For each additional episode of delirium recorded, the risk of these adverse outcomes climbed by another 6 to 17%.
So it accumulates.
Cumulative damage. If a patient gets delirium in January and then goes back in March and gets it again, that alarm bell is deafening. That is a patient who is teetering on the edge of massive systemic failure.
I have to play devil's advocate here for a second because I know there is a listener screaming this at their speakers right now. What about dementia? We know that people with dementia get delirium. We know people with dementia fall. We know they get incontinence. Isn't this study just measuring the progression of dementia?
That is the elephant in the room, and the researchers knew it would be. So they did a sensitivity analysis.
They ran the numbers again.
They ran the numbers again, but they excluded everyone with prevalent dementia. They just took them out of the data set. The findings held up.
Oh.
Delirium is an independent predictor. It stands alone. Whether you have dementia or not, if you experience this acute confusion, your risk for physical collapse skyrockets.
That is the smoking gun. You can't just blame it on the Alzheimer's. This is a distinct warning sign.
It is. And it brings us to the so what implication.
Yeah.
Because right now, our healthcare system treats delirium like a nuisance. It makes the nurse's job harder, it scares the family, but once it settles, we move on.
We treat the infection, we fix the hip, and we send them home.
And this study argues that is, well, it's negligence. Not intentional negligence, but systemic negligence. If we accept delirium as a sentinel event, then discharge cannot just be good luck, see you later.
It sounds like we need a post-delirium protocol.
Think about it like a heart attack. If you have a heart attack, you don't just go home. You get cardiac rehab. You get a nutritionist. You get monitored. You are labeled a cardiac patient.
Because we know the heart is vulnerable.
Exactly. Well, if you have delirium, we now know your entire body is vulnerable. Your kidneys, your balance, your skin integrity. So where is the delirium rehab?
What would that even look like?
It would have to be holistic. If a patient had delirium, they should be flagged as high risk. Before they leave the hospital, there should be a plan for fall prevention. Maybe an occupational therapist goes to the home to remove trip hazards.
And the kidneys.
Rigid hydration protocols. We know they're at nearly double the risk for acute kidney injury. So we need to make sure they're drinking water, that their medications aren't too hard on the kidneys. We need to be monitoring their blood work every few months, not every year.
It seems so obvious when you say it. The check engine light came on, so let's check the engine. But instead, we're just grateful the car is still moving.
We are missing the window.
Yeah.
The study says we have about a year before these bad things tend to happen. That is a golden window for prevention. But we are squandering it because we view the delirium as a past event rather than a future predictor.
This is empowering, though. If you are a listener and you are in this situation, maybe your mom is in the hospital right now and she's confused, you can actually do something with this info.
You can be the advocate. You can tell the doctor, look, I know the confusion is clearing up, but I've read about delirium being a sentinel event for falls and organ issues. What is our prevention plan for that?
Don't let it be a footnote in the discharge summary.
Never a footnote. It should be the headline. Patient experienced delirium. That should trigger the alarms.
It's interesting. We are always looking for these high-tech ways to predict the future. We want genetic tests. We want AI to read our scans. But here we have a very low-tech, very visible sign. A person gets confused. And that tells us more about their future health than almost any fancy test could.
It's a behavioral biomarker. It's free. You don't need $1 million machine to see it. You just have to be willing to look at it and accept what it means.
I want to zoom out for a second. This study used data up to 2022. It's looking backward. If we look forward, how does this change the future of geriatric care?
I think the concept of sentinel events could revolutionize preventative medicine. Imagine if we stopped seeing hospital complications as failures and started seeing them as information.
Information.
If a patient gets delirium, instead of the hospital saying, oh no, we messed up, or this patient is difficult, they say, aha, this patient has just revealed their vulnerability to us.
It's like a stress test they didn't sign up for, but now we have the result.
Exactly. And now that we have the results, we can build a shield around them. We can use that delirium episode as the trigger to get them resources they wouldn't have qualified for otherwise. Maybe getting delirium is what qualifies you for a home nurse or for a specialized nutrition plan.
So it becomes a golden ticket to better care rather than a mark of doom.
That's the hope. Prehabilitation for the next phase of life. We know the fall is likely coming. Let's armor up against it.
It shifts the mindset from treatment to defense.
And that is where medicine needs to go. We are very good at treating broken hips.
Okay.
We are not very good at preventing them. This study gives us the target list of exactly who needs that prevention.
The target is the person who didn't recognize you in the recovery room.
That's the one.
It is a heavy topic, and I know for anyone who has watched a loved one go through delirium, it's emotional. It's hard to see someone you love lose their grip on reality. But I think there is a lot of hope in this study.
I agree. Knowledge is power. Knowing the risk exists is the only way to mitigate it.
A huge thank you to the researchers behind this study. Analyzing 30,000 patient records is no small feat, and doing it with this level of rigor really pushes the field forward.
It's a landmark paper. It will be cited for years.
And thank you for helping us connect the dots between the brain, the kidneys, and the fall risk. It's all connected.
My pleasure.
And to you, the listener, the next time you hear that familiar narrative, oh, don't worry, it's just a little confusion, it'll pass, you'll know better. You'll know the check engine light is flashing, and it's time to pop the hood and take a look. Thanks for diving deep with us. We'll see you on the next one.